This conference will now be recorded.
Good afternoon, everybody. Today we will be speaking about clinical evaluation of proptosis. The topic orbit has begun for you from today. Proptosis is nothing but forward protrusion of eyes. So, am I audible to all of you? Hello, am I audible? Hello, am I audible to all of you?
Yes, sir.
Okay. So we'll go on with the topic today, clinical evaluation of proptosis. Proptosis is nothing but forward protrusion of the eyeball. It can be forward, it can be, this is basically, the protrusion is of many types. It can be axial or abaxial. Axial means straight anterior-posterior. If it deviates from its anterior-posterior direction, if it protrudes forward from anterior posterior direction, if it deviates from there, like a superiotemporal direction or superionasal direction or inferiotemporal or inferionasal, whichever direction it protrudes other than anterior posterior axis, it is called as axial proptosis. AB, axial proptosis means it is not straight, it is not in the anterior posterior line, it is deviated from its line. So normally whenever the protrusion is there, there should be something behind which is pushing the eyeball. Today we will learn how to clinically evaluate proptosis and how to analyze that evaluation of proptosis and how to come to a differential diagnosis. So proptosis as such is nothing but forward protrusion of the eyeball. There are many causes of proptosis. So anything which pushes the eyeball forward, it could be a tumor, vascular tumor, neural tumor, it could be some mass, it could be a gland tumor. There are so many contents in the orbit. So anything in tumor of any structure, tumor of any structure can give rise to forward protrusion of the eyeball. Today we will just learn evaluation. Before going into evaluation, first let's know what are the different types of proptosis. So there are different names given for different types of proptosis. For example, it could be benign or malignant. Benign or malignant, they are self-explanatory. It could be unilateral or bilateral, means the proptosis is present in one eye only, or if it is present in both eyes, if it is symmetrical or asymmetrical, or it could be pulsating or non-pulsating. Pulsating means the protrusion of the eyeball, you can see the pulsation, you can feel the pulsation of the eyeball coming forward and moving backward. So then if it is associated with the thyroid eye disease, it is called as the thyroid XOF or it is the word XOF is used exclusively when the proptosis is due to thyroid. So there are different causes. There could be metastasis which can lead to forward protrusion of the eyeball, or it can lead to enophthalmos. Enophthalmos is nothing but sinking of the eyeball inwards, and proptosis is protrusion of the eyeball forwards. So today we will try to evaluate clinically proptosis, and we'll try to see how to come to what are the important features we have to keep in mind while evaluating proptosis. So now, what are the most important clinical approach which we have to take? We have to take first three main important aspects, that is history, examination, and investigations. So here, what is the important aspect in history which you have to take? The signs and symptoms, how long it has been, what is the duration, is it associated with pain, are there any associated signs? So what is the use of these signs and symptoms? You have to see what is the location of the tumor. It will help us to evaluate how it is it pulsating or non-pulsating, it is unilateral or bilateral, is it coming anterior posteriorly, or is it axial, or is it abaxial? So different dynamics of that based on the location, how the tumor is protruding forward. These things you have to evaluate. Apart from that, once you evaluate these signs and symptoms and you localize the lesion or study the proptosis, you have to come to a differential diagnosis, and based on that you have to group the proptosis. For example, if the patient is having a proptosis of the right eye, you will see that where is it in where is what is the location is in the right eye, and is it unilateral or bilateral? It is unilateral. So dynamics, is it pulsating or non-pulsating? Is it increasing with cough or not? Different aspects you will study, and then you will formulate a differential diagnosis. A unilateral proptosis, non-pulsating, painful or not painful, or acute or chronic. Based on that, you will come to a differential diagnosis. So what are the causes which are unilateral, chronic, non-pulsating proptosis? So you will have some 3-4 differential diagnosis. Based on that, you will start investigating the patient. So you see the age and you see what is the frequency in that particular age. Then you come to an investigation which will help you to clinch the diagnosis. So what are the important aspects in history you have to take? In history, you have to identify whether the patient is having pain or not. How is the pain? Whether it is severe pain, moderate pain, dull or boring pain. So for example, if patient is having orbital cellulitis, orbital cellulitis is nothing but infection of the orbit. When there is forward protrusion of the eyeball. So the pain is usually very severe. And if there is an abscess behind the eye, if there is a keratico-cavernous fistula, or if there is a metastasis, all these conditions give rise to severe proptosis. If there is a moderate amount of rain, it can be inflammatory orbital idiopathic disease, idiopathic orbital inflammatory disease, that is nothing but inflammation of the extraocular muscles. And ruptured dermoid cyst, this could be a cause of moderate pain. And dull pain, it could be due to erosion of the bone due to neoplastic tumor. Over a period of time, a neoplastic tumor can erode the bone and give rise to dull aching pain. So pain is one important aspect which you have to take. Next most important aspect is progression. How is the progression of the proptosis? Is it acute, subacute, or chronic? If it is acute, means the proptosis has developed within first 1 week. Within 7 days, if the proptosis has developed and there has not been any proptosis before, then you suspect infections or inflammations. If the duration is 1 to 4 weeks, then you have to suspect parasitic infestations or metastatic diseases. These are all just few examples for us to formulate a differential diagnosis. And chronic, greater than 1 month, if it is there, and it is optic nerve glioma, means the proptosis has been more than 1 month duration. And this one example is optic nerve glioma. There are many other differential diagnoses, but these are few examples. So what are the effects of proptosis? What can happen when the proptosis occurs, or what is the problem with proptosis? So when does a proptosis occur? Whenever there is a trauma, or it can erode the bone, and there can be lytic lesions of the bone, then also proptosis can occur. Whenever there is a positive mass effect, a positive mass effect means, for example, if you see here, there is a lacrimal gland tumor which is pressing the eyeball, so the eyeball gets pushed inferonasal. So in downward and inward displacement of the globe due to the positive mass. So these are different effects on the eyeball. So eyeball can actually shrink inside but that is not called proptosis, but that is enophthalmos. So eyeball, the surrounding bone can get damaged due to the lytic effect of proptosis, or due to the neoplastic tumor, or due to trauma, or due to cicatrization. Anything can happen during the process of proptosis. Now, this is an example of axial proptosis. Axial proptosis, if you see this patient, left eye looks normal, and right eye of this patient, this picture, if you see, you can see that the eyeball looks forwardly protruded. You can make out the difference between the right eye and left eye. How do you establish that the right eye is proptosed? You can see just by looking at the patient, you can see that there is a scleral show here. This is the inferior border of the limbus of the cornea, and you can see the sclera is seen here. Normally the lower lid margin has to touch the limbal border. You can see in this eye here, if you see, there is a gap between the lower limbal border of the cornea and the inferior margin of the eyelid. So this is nothing but an example of axial proptosis. Something is pushing behind the eyeball and the eyeball is moving forward. It is parallel to the uh, anterior posterior axis of the eyeball. So anterior posterior axis is like this. So this is pushing it in the anterior posterior direction. So usually whenever there is a tumor which is pushing the thing, pushing the eye in the anterior posterior direction, the tumor is usually intraconal. Example for that is schwannoma, which leads to positive displacement and axial proptosis. So eyeball is pushed forward. So why this proptosis occurs? Because the volume of the orbit is maximum is 30 ml. When any tumor which occupies, there is some amount of buffer space in the orbit. So when the tumor exceeds the volume of the orbit, then there is no other chance other than the eyeball being pushed forward. So you can see here, this is abaxial proptosis. If you see in this particular picture, which eye is involved? If you see here, this eye is slightly moving downwards and inwards compared to the right eye. So if you see the fundus picture, you can see a lot of folds on the retina. So there is a downward and inward displacement of the left globe with fullness and S-shaped deformity of the lid. You can see here, this is a S-shaped deformity of the lid, and there is a downward and inward displacement of the left globe with fullness and S-shaped deformity of the lid in a patient with benign mixed tumor of the gland. So when the eyeball is pushed in this direction, there should be something in this place which is pushing the eyeball in downward and inward direction. So usually what is the anatomical structure here? It is the lacrimal gland. So whenever lacrimal gland tumor is there, it pushes the eyeball in downward and inward direction. So when something is pushing the eyeball, so it will cause folds, it will press the eyeball and it will cause folds in the retina. In the retina you can see these are all various striations like this. So these are all folds which are seen in retina. So this is an example of abaxial proptosis. Whenever there is an axial proptosis, the tumor is present in the intraconal space, and when there is an abaxial proptosis, tumor is either superotemporal, superonasal, whichever direction it is, it pushes the eyeball in the exactly opposite direction, 180 degrees to it. Now, what is the axial enophthalmos? You can see here the eyeball has sunken inside. The eyeball has gone inside. So this is an example of axial enophthalmos. If you see this particular picture and compare it to this is a normal uh, eye, whereas if you see this eye seems to have gone inside. So in a case of orbital metastasis of sclerosing carcinoma leads to axial enophthalmos. The eyeball is pulled inwards. So this is an example of axial enophthalmos. So here just I am giving a mention about enophthalmos, but our topic today is about proptosis. The next issue is Wallsolver maneuver. What is this Wallsolver maneuver? When you hold your breath, the eyeball gets pushed forward. So this is nothing but Wallsolver maneuver. Enophthalmos due to fat atrophy and enlargement of the orbit in a patient with distensible orbital venous malformation. Exophthalmos increased fullness of the lid and loss of deep upper sulcus in the same patient during Wallsolver maneuver. So you can see here this eye has gone inside. When he does a Wallsolver maneuver, the same eye has protruded forwards. See, you can see this is the sulcus margin which you can see here. When he performs the Wallsolver maneuver, then the eye gets pushed forward. So this is seen in particular mainly with the patients with orbital venous malformations. Venous malformations is nothing but the veins which are present in the orbit, superior ophthalmic vein, inferior ophthalmic vein, all these veins start to get dilated. So when they, just like varicose veins, these veins get dilated. So these patients are likely to develop proptosis only when they perform Wallsolver maneuver. When they hold their breath for some time, the eyeball gets protruded. Now coming to examination. Till now we have just seen what is the history, how the proptosis is, whether it is axial or abaxial, how to evaluate it, all these aspects we have seen. So now let's come to examination of a proptosis. In examination of the proptosis, mainly we have to remember this letter P. There are some books give 7 forms of P, some books give 9 forms of P, some books give 11 forms of P, but it is just a mnemonic to remember. But you have to perform all these tests to evaluate a case of proptosis. So what are those P's? The first P is proptosis. P for proptosis is nothing but first you evaluate whether the proptosis is mild, moderate or severe. Normally, the eyeball from the left orbital margin is around less than 21 mm. The anterior surface of the cornea, the protrusion from the when you compare it to the lateral orbital rim is less than 21 millimeters. But if it is more than that, then it is mild. But below 23 is called mild. When it is protruded beyond 23 millimeters, 24 to 27 is called moderate, and if it is more than that, then it is severe proptosis. Next one you have to look for is pulsation. You have to feel for the pulsation, whether they are transmitted, whether it is coming when the patient coughs, whether it is related to heartbeat, whether you can feel the bruit. When you perform an applanation tension, you can see that whether the patient is having pulsation, whether it is a pulsatile proptosis or not. Means when a proptosis is pulsatile only when there is some communication between with a major vessel. For example, keratocavernous fistula, cavernous vessels and carotid vessels, cavernous sinus and carotid vessels. When there is a fistula between these two, there is a forward protrusion of the eyeball, but which is pulsating, which you can make out in the when you are performing an applanation tension for the patient. Applanation tension is nothing but when you check for the intraocular pressure, you use this method called as applanation method. Next one is you have to check the most important thing in the examination is pupil. Why you have to check for pupil? The whole purpose of treating this proptosis is to preserve vision. If the vision is not preserved, then whatever you do for the proptosis is going to go in vain. So proptosis, the main aspect what you have to check is the visual acuity, and you have to see how the pupils are. It just tells us what is the status of the optic nerve. Next, palpation. All these are P's which you have to keep in mind when you are performing an evaluation for proptosis. You have to palpate and see what is the status of proptosis, whether it is firm, soft, whether it is you are feeling a bag of worms like in neurofibromatosis, or whether you are feeling pulsatile or not. All these are palpatory examinations. Next one is PBCT. PBCT means prism bar cover test. It helps us to evaluate what is the amount of deviation from the center the proptosis is present. So that I will show you in the next example, next slide. Next is perception and color vision, perimetry and fundus changes. All these are nothing but optic nerve function tests and macular function tests. You have to evaluate the fundus, do a perimetry, and you have to check how the color vision is. All these things will tell us what the status of optic nerve, whether the optic nerve is functioning normally or not. Then the next one is periorbital changes. Periorbital changes is what is happening around the orbit, whether there are changes like salmon colored mass in cul-de-sac or corkscrew vessels. So these are all seen in few conditions which have to be identified. Wallsolver is nothing but these are extra maneuvers which help us to identify whether the proptosis is pulsatile or whether it is due to varices. These Wallsolver help us to identify whether the proptosis is secondary to vascular condition or not. So basically these P's you have to remember: proptosis, pulsation, pupil, palpation, PBCT, that is prism bar cover test, perception of color vision, perimetry, and periorbital changes. So we have around 8 P's here. Some books give 7 P's, some books give 9 P's. So basically, you have to, in your examination, you have to concentrate on all these P's while you are examining a patient with proptosis. Then a systemic evaluation is a must to identify any signs of metastasis. So now coming to PBCT, what is this PBCT and how do you do this PBCT and how do you evaluate what is the extent of proptosis, how do you measure it, all these aspects we will go through in brief. So if you want to see what is the amount of proptosis, you take the center of the pupil here, and this is the center of the pupil, this is the limbal border, this is the nasal point. From the nasal point you measure the horizontal distance. Okay, the distance in millimeters at the level of canthi from the center of the nose to medial edge of the limbus. So you measure from the center of the nose to the along the medial canthus. So this is the medial canthal area. This is the medial canthal area. You measure the distance. So you measure how much it is deviated from the normal. So you note down the measurement. Similarly, you do it for both the sides. And if the you do it for the right side and you do it for the left side. Then the vertical displacement. You measure the vertical displacement of the eye by recording the position of the globe above and below the medial canthi. So this is the medial canthi, and you make a note how much above or below the globe has been displaced. This is the normally, if you see, the line has to cut through the center of the pupil, the medial canthus and the center of the pupil. The line has to cut through that. You see how much the pupil is displaced upwards, and you keep a vertical scale there and you measure how much the pupil is displaced upwards. Based on that, you can say whether it is upward displacement or downward displacement. For example, in this picture there is a downward displacement in the left eye and upward displacement in the right eye. This is just a diagrammatic representation to help you to understand what is the upward displacement and what is the downward displacement. So that will help you to identify how much the proptosis is how much proptosis is abaxial or elevated or depressed. Now this is the instrument which is used to identify the amount of proptosis. This instrument is called as Hertel's XOF Thermometer. So now what is this Hertel's XOF Thermometer? You can see this is the lateral orbital rim margin, and this is the instrument called Hertel's XOF Thermometers. There are mirrors placed inside it has a prism with mirrors placed in inside the prism. This anterior point of the cornea, the reflection of this will fall on the mirror here, and it will be matching with one particular reading here. The examiner sees that particular reading and he identifies the level of the proptosis. Say for example, in this patient, you can see here it is between 15 and 20. So somewhere the reading is somewhere between 17 and 18. So this is the normal patient. So suppose if this eye is protruded forward, it will get you can see this reading coming more forward. So and this is just a diagrammatic representation. It is not the exact value. The reflection of this anterior surface of the eyeball, that is the anterior surface of the cornea, is seen in the mirror and it is matched with the readings which are present here. Now this bar which is there here, this is called as base reading, because when you perform the test, you might have kept the support on the lateral orbital rim at this particular points, and somebody else might keep it more closer or somebody else might keep it away. So to maintain a standard among whoever measures, there is something called as base readings. You can see here this is 100, and somewhere here might be 120. So next somebody else tests the proptosis, he should also keep the instrument at the same level, that is at 120, and measure the amount of proptosis. So I hope you understood about XOF thermometer. For you, for undergraduate level, if you know that this is the instrument which is used to measure proptosis, it is more than sufficient. Now this is an example of how to use an Hertel's XOF thermometer. You can see that these are the supports where it is placed on the lateral orbital rim. One eye is occluded with the thumb of the examiner, and you note down the base readings. And this one is fixed, and this is a sliding scale. And you measure, you see these readings here like this, like in the previous picture I showed. There is a mirror, and then these are the readings, and it will show the value of the protrusion on this scale. So that is what this is the scale which is seen inside, and then based on that you take the readings of proptosis. You can see in this particular picture the reflection of the anterior surface of the eye is seen here. It is matching with one particular value. That value and this base reading value is taken into account. You can see here this is 10, this is 10, 20 and 30. So somewhere the value is it is showing around 15 to 16. Between this, you can see the anterior surface of the cornea, the reflection of the anterior surface of the cornea is seen here, and this is the reading which you have to take, that is 15.5, and the base reading, if you see here, it is 120. So you will record it as 121 base reading, and then the reading of the eyeball, anterior surface of eyeball is 15.5. This is how you record it. So basically summarizing evaluation of proptosis as far as undergraduate level is concerned, first we have to try to formulate a differential diagnosis, whether it is unilateral, bilateral, or whether it is pulsating, non-pulsating, benign, malignant, whether it is acute, chronic, or subacute. Differential diagnosis based on the duration, pain, symptoms. You have to formulate a differential diagnosis. When it comes to evaluation, you, as I said, you have to evaluate all the P's: proptosis, pulsation, pupil in the anterior segment examination, and you have to palpate. You have to do a prism bar cover test. Prism bar cover test is to identify the amount of deviation, and perception of color vision, perimetry, fundus changes, periorbital changes, Wallsolver maneuver. These are the maneuvers which are to be performed in the examination. A thorough systemic evaluation also is important because many systemic diseases do cause proptosis. So to summarize the evaluation aspects, first we have to see whether the disease is inflammatory, infiltrative, or vascular, or is it a tumor, or is it a mass effect. And then your clinical examination will proceed accordingly. The next thing what you have to do is you should see the effect of the disease. What is the psychophysical changes, what is happening, what are the motor effects, what are the sensory effects, which are the nerves involved, which are the muscles involved, is the movement affected, is the optic nerve affected, is the third nerve affected, is the fourth nerve affected, is the sixth nerve affected. All these things you have to evaluate. And the next thing what you have to do is you have to order for imaging or investigation. Imaging is once you formulate a clinical or provisional diagnosis or a differential diagnosis, the next thing what you have to do is imaging to identify the cause. So different commonly ordered imaging is CT scan. With CT scan, most of the orbital lesions can be identified, but if soft tissue is involved, you can also ask for an MRI. So CT scan is the mode of investigation. X-rays are also asked, but most commonly nowadays CT scans are asked for. So what are the issues you have to localize in case of imaging. In imaging, you have to identify the location, how the surface is, and what are the surface features, whether it is an infiltrated region, what is the effect of the tumor on the adjacent structures. All these can be analyzed on imaging. And based on the type, if you want to identify what is the exact lesion, based on the physiology, vascularity, whether compressibility, and positional change and functional change, by doing a PET scan, also you can identify the activity of the tumor, whether it is vascular, whether it is compressible, whether it is there is a positional change, all these things. So mainly CT scan is the mode of imaging. So I hope in brief I have covered the evaluation of proptosis. Uh, it all depends on the clinical disease, how, what clinical disease you are dealing, and how you are going to approach, what are its effects on the orbit and the eye, and how you image, and what are the clinical examination you do, and how you proceed accordingly. So this is in short about evaluation of proptosis. So, rest, if you have any clarifications, please go through the textbook. And if you have any doubts, you can always contact us. Uh, just go through these aspects in your textbook so that you have an idea about proptosis. First, read up the anatomy, and then uh, try to understand how the proptosis case is present, and then read up about the clinical evaluation. When we go on to each condition in proptosis, or in each clinical condition, then these examination aspects will be more clearer. Okay, thank you very much.